So these are the boundaries. So anteriorly, so on the left side of your screen, ayan yung naka-side view siya. I hope you can recognize the lips on the anterior portion, okay, as seen with some of the parts of the lips. Ayan yung vermilion border. Okay, you have your orbicularis oris muscle. Okay, so that's your lips. And then the space between the lips and the teeth, again, is your oral vestibule. So anteriorly, it is bounded by the lips. Okay, laterally, on the side, if you look at the other photo, so ang view nito is anterior view. You will see the cheeks. So that's the lateral boundary. Okay, and then superiorly, as well as inferiorly, it is bounded by the mucolabial and mucobuccal fold. Okay, so you will see that again on the right photo on your screen. Okay, you will see there the mucobuccal fold. So there's part on the lower as well as the upper, of course. And then posteriorly and medially, it is bounded by your teeth and the periodontal structures. Okay, so those are the four boundaries of oral vestibule. Okay, so, and once we examine the vestibular area, you will see this structure. So I know you know this. This is your labial frenum. There's one on the upper arch and one on the mandibular arch. Okay, so both of them are referred to as labial frenum. Okay, and again, this is your labial vestibule, the entire uh, front area. Okay, that's the one um, on the labial area or your lips or the labial vestibule. Pag nasa cheeks na siya, that's your buccal vestibule. Okay, of course, you have one on the lower and on the upper. So again, this is your buccal vestibule. And on your buccal vestibule, okay, you will see that is your cheeks area. Okay, so there's a structure there, a rounded cheeks. Okay, everyone has this. This is the parotid papilla. So if you have a mirror, you want to examine your um, the exit of your parotid gland, okay, and duct. So that's your parotid papilla, okay, an elevation, and your linea alba. Linea alba is the one pointed by the arrow. As the name implies, it forms as a line. Okay, kaya linea alba. Okay, so that's the vestibular area. Now we go to the oral cavity proper. When the patient opens his or her mouth, this is what we see. And it also has boundaries. So anteriorly and laterally, okay, it is bounded by the dentition and the supporting structures, including the gums and the alveolar bone or process. Okay? And then superiorly, it is bounded by the palate. And the palate has two parts, the hard palate and the soft palate. Okay, so later we'll see that closely. Okay, and then inferiorly, it is bounded by the tongue and the floor of the mouth, and posteriorly by the opening into the pharynx. Okay, so those are the boundaries of the oral cavity proper. And if we look at it closely, this is the retromolar trigone or fossa or area. So it forms a triangle. That is why it is called trigone. And with the triangle, the parts of a triangle, meron siyang apex and base and the lateral side. So on the apex part is the maxillary tuberosity area. So the maxillary tuberosity is the one is the bone Can you see the pointer? Siyempre hindi, no? Wait lang. Let me try to close this. Can you see the pointer?
Yes po.
Okay, so this is your maxillary tuberosity. And then on the lateral side, you have the gingival buccal sulcus as well as the pterygomandibular raphe. So this one is your pterygomandibular raphe. Okay, and then this is your buccal sulcus. And then on the base is your the distal part of your mandibular molar. Okay, so that's your retromolar trigone or fossa. This area is important, especially on administering inferior alveolar nerve block or ion block, which is a type or a technique we use in anesthesiology. Okay? And of course, this we know already because you had your Gen Ano 1. The oral cavity is composed of teeth. Okay, so it has major parts, the crown and the root. Okay, and the neck, okay, is sometimes we call that a CEJ or your cemento enamel junction. Okay, and internally, if we dissect the tooth, you will see the layers. You have your enamel, the dentine, the pulp, and on the root area, you have your cementum. On the root area, we don't have enamel. Okay, and the supporting structures. The supporting structures, you have your alveolar bone and your gingiva. Okay. And on the gingiva, this is how it looks like. It is divided into um, two major parts, the alveolar mucosa and the attached gingiva. Okay, and in between the alveolar mucosa and your attached gingiva is your mucogingival line. Okay, and the part of the gums nearest to the tooth is what we refer to as your marginal gingiva. Okay, and then here on the right side, you will see some stippling on the attached gingiva. And this stippling you can usually see um, on a healthy gums or um, gingiva. Okay, pag this one has gingivitis, periodontitis, since the um, gums become loose, you will learn that more on your perio class or periodontology subject. Okay, the stippling may vanish. Okay, and the gingiva is usually the color, the normal healthy gingiva, the color is coral pink. Okay. So now we go to the sublingual region. It has the following characteristic features. Anteriorly, it has the anterior two-thirds of the tongue. Okay. Pag naka-lie down yung tongue dyan, di ba, the anterior two-thirds of the tongue, okay, the ventral side lies on this region. Okay, you also have your lingual frenum. This one, this is the attachment. And then you have your lingual veins that are plenty. So when you are extracting a tooth and you don't do some finger rest, okay, you may easily uh, rupture a lot of blood vessels in this area and um, stopping the um, blood um, flow from this area is very hard kasi maraming capillaries and as well as major veins that are kind of superficial in location. And then you have your sublingual caruncle, this one. Then your sublingual folds and your fimbriated folds. Okay, just a closer view. Okay, now we go to the muscles of the floor of the mouth. Okay, so you have the following muscles. Okay, you have your geniohyoid muscles, mylohyoid muscle. Okay, so the hyoglossus also, however, this is a cut view. Okay. So those are the muscles that you can find on the um, floor of the mouth. Okay? Sila yung mga immediately there. Okay? And the mylohyoid muscle, you know, on the skeletal part, on the mandible, it is attached to the mylohyoid groove, okay? Or ridge or line, okay? And on the hyoid bone. Okay? Sorry, this one is supposed to be earlier. This just shows the gingival area. Alright, so now we go more posteriorly. So we have the oropharyngeal area, which is shown in this photo. So this is your oropharynx. Okay. So on your oropharyngeal area, you have your hard and soft palate area. So in this clinical view, you will see the hard palate area, although the hard palate is under the mucoperiosteal uh, region. Okay? The actual bone is under the soft tissues. Okay? And then we have the soft palate. So the palate forms the superior wall or the roof of the oral cavity proper and is composed of an osseous base and fibrous tissue. Okay? So this is your hard palate. And on the first few modules, you have learned the parts of the skull, okay, and the palatal region was covered there. So again, your hard palate is covered by a mucoperiosteum, and this region forms a partition between the oral and nasal cavity because more posterior to the soft palate is your nasal region also. Pharyngeal, and then on the superior portion is your nasal cavities. Okay. Just a closer view. The important parts there are, of course, your incisive foramen, because major nerves are exiting through this foramen. So when we extract or when we extract or perform surgery on the anterior region, or if you want to anesthetize the some parts of the anterior portion of the maxilla, especially on the palatal side. Okay? It is the nerve passing through the incisive foramen that we anesthetize. Okay? And on the posterior portion, you have your greater palatine foramen, which is also an important foramen because you will see on the next two modules, or I think module 7, uh, that is about the trigeminal nerve. Okay, you will learn what nerve passes through this region. Okay, so the nerve is the greater palatine nerve, and it innervates the most of the posterior region, including the posterior teeth. Okay, so those are some of the very important landmarks. And the clinical, some characteristic features, again, you have your median raphe. So it is a longitudinal ridge extending from the uvula to the incisive papilla. So uvula is the portion that when you open your mouth, the one in the middle, okay, yung nakasabit doon. So that's your uvula. And you have your incisive papilla. So kanina we are looking at the osseous structure or the bony structure. Now we're looking at the palatal region with the mucoperiosteum. Okay, so above your incisive foramen is an elevation. Okay, so this is a small projection that we call as incisive papilla. Okay, so when you are shown with a slide or a specimen, if it has mucoperiosteum and the arrow points in that region, okay, that's the incisive papilla. But if you're given with an osseous structure, you should answer the foramen. Okay. We also have the transverse palatine process or the palatine rugae or simply rugaes. Okay, so these are about 6 distinct elevation crossing the anterior part of the hard palate. And when we do denture making, whether it's a complete denture or a removable partial denture, so you on the impression material, you have to clearly uh, get an accurate impression of these regions, okay, because the rugaes will also help at some point with the retention of your dentures. Okay, so it increases the surface area on where the denture will hold on to, okay, especially for complete denture cases. And then we have the fovea palatine. So the fovea palatine are two small inconstant teeth on the posterior margin of the hard palate on both sides of the median raphe. Okay, so hindi siya kita dito, but, sorry. If estimating the location, it will be somewhere here and here. Okay, two dots here. But case-to-case basis, for some patients, the fovea palatine, okay, are not very distinct. Okay, so there. So that's for the hard palate. Okay, sorry for the format. I think when I transferred it to the Google Drive folder, ayan, na-display siya. So we now go to the soft palate. So with the soft palate, okay, still on the oropharyngeal region, we have the uvula. Again, this is the median conical projection marked by the median raphe. So in this photo, it is this one. Okay, and the median raphe is this one. Okay. And you have your palatine arches. So these are free margins of the soft palate, and it splits into two parts as they approach the lateral wall. So there are two palatine arches. So you have the palatoglossal arch or the anterior pillar of fauces. Okay, so they are the same. So when you come across reference books, don't get confused. Okay, that's the same. So again, palatoglossal arch and the anterior pillar of fauces or anterior palatine arch. Okay, it encloses the palatoglossus muscle, hence the name. Okay, that is why it's called palatoglossal arch. So the arch is formed by the palatoglossus muscle. And in this photo, on the lower photo, it's the one with letter A. Okay, that's your palatoglossal arch. And next will be the palatopharyngeal arch or the posterior pillar of fauces. So on the first few slides kanina, if you remember, the opening between the oral cavity to the pharynx is what we refer to as fauces. Okay? So the name of the palatoglossal arch again is the anterior pillar of fauces. Okay? The posterior pillar is the palatopharyngeal arch, which is the letter B in the photo. Okay? And with the name, the muscle that the arch encloses is the palatopharyngeal muscle. Okay, so this is just another view. Okay, so these are the muscles of the soft palate. The one on the with the green border box. Okay, so these are the muscles. So on the posterior view, you will see the tensor veli palatini muscle. Okay, this one. And then you have the uvular muscle. So the uvula is composed of a muscle. Okay? And then we have the levator veli palatini muscle. Okay. And the on the posterior view, the muscle that you will first see here is the levator veli. And then if you cut it, okay, more anterior to this muscle is your tensor veli. Okay? And then on the inferior area or region is your palatopharyngeal muscle. Okay, so this is, of course, where the palatopharyngeus or palatopharyngeal arch is. Okay, and your palatoglossus, the anterior arch of fauces. Okay, and this will show you the summary of the OIA or the origin, insertion, and action of the muscles of the soft palate. Okay, are you still with me? Nandyan pa ba kayo? Can someone respond? Baka mamaya wala na.
Yes po.
Okay, sige. Gising pa kayo ha. Sakto sa siesta time yung class natin eh. Okay, so let's go through it one by one. For the palatopharyngeus or palatopharyngeal muscle, the origin is the palatal aponeurosis. Okay, and then the insertion is the lateral wall of the pharynx and posterior border of the thyroid cartilage. And the action is it elevates the pharynx and larynx and closes the oropharyngeal isthmus. Okay, the palatoglossus, on the other hand, it has the same origin with the palatopharyngeus. Okay. The insertion, however, is the dorsum and lateral aspect of the tongue. So the action is it closes the oropharyngeal isthmus. Now, for the uvular muscle, the origin is the posterior nasal spine. Okay, and the insertion is the uvula. It raises the uvula to help seal oral from nasal pharynx. And the last two muscles of the soft palate is your levator and tensor veli palatini. So for the levator, this is the origin, the medial aspect of the auditory tube. For tensor veli, it's the lateral aspect, okay, of the membranous portion of the auditory tube with the scaphoid fossa from the sphenoid bone. The insertion for the levator is directly into the palatine aponeurosis, while for the tensor veli, the insertion is on the tendon hooks under the hamulus. okay, and inserts into the palatal aponeurosis. So the action, okay, is almost similar. Both of them are can elevate the palate, okay, during swallowing and yawning. Okay. So now we go to the tongue. So that's for the oropharyngeal. Now we go to the tongue. It has different parts. In this photo, you will see the root portion and the body portion. So for the root, and as for the tongue is uh, a mobile mass of muscles lying on the floor of the mouth, and it is associated with the function of taste, chewing, swallowing, and speaking. Okay, so any problem with the um, tongue area would um, probably affect any of these functions. Okay, it will be difficult to speak. Later, you will see some clinical relevance on the last part. Okay, so for example, on the frenum attachment, on the lingual frenum attachment, okay, if that is too short and it restricts the tongue movement, okay, the patient will have difficulty speaking or talking. Okay, so let's go to the parts for the root. It is the lower portion of the posterior half of the tongue through which the extrinsic muscle, blood vessels, and nerves become connected with the organ and is attached to the mandible and the hyoid bone. And you have the body, which is the anterior part of the tongue, made of interlacing skeletal muscles. Okay, so for the body, it has the lingual papilla, also the median sulcus, okay, as seen in this photo, the foramen cecum on the more posterior region, okay, the depression there that appears like a parang hole is your foramen cecum, and the sulcus terminalis, the V-shaped part. Okay, so this comprises the body. For the margins are the lateral portion of the tongue. Okay, it is described as free and blunt in relation to the gums and teeth. Okay, with the presence of dentition, especially on the mandibular area, the tongue will, for patients, the tongue will appear uh, somewhat narrower depending on the position of the teeth. Okay, but for completely edentulous patients, you will notice that once you fabricate the denture, um, they become uneasy or uncomfortable at the start because the tongue is used to having a wider and freer space to move, okay, for the completely edentulous. So sometimes the tongue would even rest on the alveolar ridge, okay, if the patient is completely edentulous. Okay, so those are some clinical applications. So when the patient complains that the tongue, that he or she experiences difficulty controlling the tongue with the new denture, you just have to inform the patient that uh, he will get used to it eventually. Okay, right. So the next part will be the tip or the apex. It is the pointed and free or the anterior free end, then the inferior surface. So it is seen when the tongue is turned upwards. Okay, so the dorsum of the tongue is described as slightly convex anterior posteriorly and is divided into two parts by the V-shaped groove. Okay, so the two parts is the root and the body. Okay, yung groove is formed by the sulcus terminalis or the linea terminalis. It's the same. Okay, On the photo, it's referred to as sulcus terminalis, but on some references, it is linea terminalis also. Okay, so this was mentioned a while ago, the parts of the dorsum part of the tongue. Sa body, you will see the median sulcus, okay, the foramen cecum. Okay, but on the root, okay, you will see the palatine part, the pharyngeal part, and glossoepiglottic fold. Okay, so within the tongue, you will see some papilla or papillae. So you have three forms or three types. We have the valate or circumvallate papillae. Okay. We have the fungiform papillae and the filiform papillae. Okay. So for the valate, this is the largest in number. This is largest and the number is around 7 to 12 in this region. Okay? And the fungiform papillae, on the other hand, has fewer in number and are limited to the tip and margins of the tongue, okay, as seen on this photo. Okay, again, for the valate, it is the largest, usually 7 to 12 in number, and the location is this one. It is usually near the sulcus terminalis. Okay, and the fungiform, fewer in number, usually on the tip or on the margin of the tongue. And the filiform papillae are the smallest, but the most numerous and scattered uh, in the tongue, usually on the anterior two-thirds of the dorsum of the tongue. Okay. And within those papillae, okay, you will see these receptor organs for the special sensation of taste, hence taste buds. Okay, so they are pale oval bodies, most of which are located surrounding the valate papillae. Okay, a few around on the fungiform and folate papillae. So a few taste buds are scattered through the epithelium of the oral surface of the soft palate, as well as also on the pharynx and on the epiglottis area, but mostly are located on the dorsum of the tongue. Okay, so in this photo, yan, this is the valate papillae and the taste buds. Okay, can you see that? Okay, so that's where the taste buds is. Yeah. So also still on the tongue, as we've said, the tongue is a muscular part. Okay? It has extrinsic and intrinsic muscles. So when we say extrinsic muscles, so these are muscles that are found on the exterior part of the tongue, okay? Whereas for the intrinsic, okay, this is the muscles and comprising the one that we see as tongue, okay? But under that, you will know na malaki pa yung dila natin. Okay, and the focus will be on the extrinsic muscles. Right? So we have these muscles, three. So the genioglossus, hyoglossus, and styloglossus. So in this photo, okay, this is your genioglossus. Right? On the left photo, left side of your left hand side of the screen, okay, you will see the genioglossus and then the styloglossus. Okay, and the hyoglossus. So from the name, for the origin of the genioglossus, the origin is the genial tubercle of the mandible, and the insertion, okay, is the tongue or the glossal area, hence genioglossus. Okay, so in with the names of the muscle, usually the first name is the origin and the connecting name is the insertion. No, if you notice genioglossus, the origin is the genial tubercle, the insertion is the tongue or the glossal area. Okay? And the action is it retracts and depress the tongue. Okay, retract is when you move the tongue posteriorly. Depress is when you move it towards the um, uh, floor of the mouth. Okay? The second muscle, extrinsic muscle, is the hyoglossus. The origin is the hyoid bone, and the insertion is the posterior half of the side of the tongue. Okay, and same with the genioglossus, it can depress the tongue. Okay, for the styloglossus, the origin is the styloid process of the temporal bone, and the insertion is the whole length of the tongue. And the action will be to pull the tongue upwards and backwards. Okay. So just on sagittal section, the following are the extrinsic muscles. Okay, for the intrinsic muscle, you have three: the superior and inferior longitudinal muscles, the transverse muscles, and the vertical muscles. So for the superior and inferior longitudinal muscles, these are located close to the dorsum of the tongue, and the function is to shorten the length of the tongue and to curl the tip of the tongue uh, and back. Okay? So those who can do some tricks with their tongue, most likely the intrinsic muscles are very active or very much used. Okay, so the transverse muscles, on the other hand, the action is to narrow the tongue. Okay, for the vertical muscles, the function is to flatten the tongue. Okay, nakuha ba yon? Yung function niya? So this is just on a different view. This is the anterior view. So you will see the vertical and transverse muscles. Okay, so para siyang interweave type of muscle. Then you have the inferior longitudinal muscle. Okay, and the superior longitudinal muscle of the tongue. Alright, the one nearest to the dorsum of the tongue is your superior longitudinal muscle. Okay, so just a summary of the action of the muscles of the tongue. Okay, for protrusion, you only have the genioglossus. Okay, so retrusion, you have the hyoglossus, styloglossus, and genioglossus. For depression, you have genioglossus and hyoglossus. For elevation, si styloglossus lang yun. Okay, so those are the extrinsic muscles. For the tricks, okay, for the shortening of the tongue, we have the longitudinal intrinsic fibers. For narrowing, you have transverse intrinsic fibers, and flattening is your vertical intrinsic fibers. And with regards to the nerve supply, for the anterior two-thirds, we have the lingual nerve for the general sensation. For special sensation, we have chorda tympani, And for motor innervation, we have the hypoglossal nerve. Okay, and for the posterior one-third of the tongue, the innervation or the nerve supply is from the glossopharyngeal nerve. Okay, siya lang. For all, regardless if general sensation or special sensation. Okay, for the clinical relevance, so this is called ankyloglossia. Ankylosed, kaya ankyloglossia, meaning the tongue seems to be uh, ankylosed to the floor of the mouth. Okay? For layman's, we call it as tongue-tied or tongue-tied. Okay? So this is when the large lingual frenum limits the mobility of the tongue and interferes with speech. So how do we repair it? So by lingual frenectomy or the cutting of the frenum. Okay, so usually we detect it with children. So since during some time on their early years, there's a time na dapat they are already speaking or talking some syllables or words. Okay? For some children, they cannot. And upon examination, we usually see this. Okay? So again, the repair, how to address this is by frenectomy or lingual frenectomy. And some other concerns will be presence of squamous cell carcinoma or simply tongue cancer. Usually, with oral cancer, there are a lot that you can find on the tongue area because the tongue is composed of many glands, okay, that are very prone to blockage, and the tongue is usually exposed to a lot of friction. Okay, so that's why it's a common site for um, some forms of cancer or carcinoma. And we have the paralyzed tongue. So, for example, any fracture to the mandible may damage the hypoglossal nerve. Okay, and this pulls the tongue to the same side where the um, fracture, where the mandible fractured. Okay, and also sometimes during general anesthesia, okay, it may result to paralyzed tongue. Okay, and uh, it is shown as the tongue is loose, okay, or the patient cannot control the tongue. Okay, and also one problem is if you cannot control your tongue, you know that there's a part that is located on the pharyngeal area that's still a part of your tongue. Okay, sometimes it can block the airway, causing some forms of suffocation or blockage on the patient's airway. So that will be very alarming. Okay, so on your clinical years, you'll be taught um, you have a subject on oral diagnosis as well as oral pathology. So you will be zooming in to the pathological concerns on the oral cavity. But for now, this is anatomy class. So, okay, you just simply have to understand and master the parts or the anatomy, its functions. Yun. Okay, so these are the references for this module. Okay. So, are you okay? Okay lang ba kayo? Are you still there? I'll be checking the attendance. So for this afternoon, we will be some sort of maximizing the time. Kasi short lang naman yung module after this, the salivary glands and accessory glands. So we'll talk about it already. Since we are already